I'm sure they will.
Hi, everybody. Thanks for coming today. I'm glad you could all, spend some time with us on a, Saturday afternoon to talk about medicine and medical school. And so we have with us today 3 former Shawnee State students who are all now, finished medical school and working as doctors. So we have Dr. Andrew Pollard, Dr. Baird, and Dr. Cody Carter here with us today. So I'm just going to turn things over to them, and there will be time, I guess, after their presentations for you to ask questions. So, once that we have time for questions, just turn on your microphones, unmute, and, go ahead and ask your questions. Okay, take it away, guys.
Cody, I think we could probably, and Zach, I think we could start with like a little bit of introductions on, when we graduated from Shawnee Med School, that whole deal. Cody, Cody, if you want to start.
Yeah, so me and Zach have known each other for a long time. We kind of grew up around southeastern Ohio, a place called Rye Branch, about an hour away. And then we met Pollard in undergrad, and really got involved with the pre-med club. I think with Zach actually got me, piqued my interest at Shawnee with their cadaver program and Dr. Burns and things like that. I didn't really know a whole lot about it until Zach piqued my interest, and then we went down there and then really saw how good it was and the opportunity to work with those, and then how dedicated Dr. Burns and at the time Dr. Oliver was to diagnostic micro and cell biology and things like that. So and then we went to Shawnee for 4 years, and then me and Zach ended up going to Ohio University for med school. He graduated internal medicine. I took a gap year, and then he graduated internal medicine residency, went to Riverside in Columbus, and I went to Doctor's Hospital, which I'm still at right now. He's doing he's doing a pulmonary critical care fellowship in Louisville, and he's going to start in July, and I am coming up on my 3rd year of internal medicine residency. I'm planning on doing cardiology after that. I think I'd like to do interventional after that. But it'd be 4 years of undergrad, 4 years of med school, and then internal medicine's 3 years. And all 3 of us have either done or are doing that right now with the 3 years of internal medicine residency. And then Pollard's doing a cardiology fellowship right now. And then Zach is about to start a pulmonary critical care fellowship right now.
So, Zach, you have anything first?
Oh yeah, Cody pretty much did all the introductions for us. Very nice.
Yeah.
But yeah, no, I graduated from Shawnee State in 2013. Went to OUH-COM down in Athens. This is before they had the other 2 campuses. Now they have campuses both in Dublin and Cleveland. But I completed my 2 years in Athens. OU, for your clinical rotations, your 3rd and 4th year, you go away from the Athens campus. So I went back down to Southern Ohio, did my 3rd and 4th year of medical school at SOMC, and then graduated from OUH-COM in 2017, went to Ohio Health Riverside here in Columbus, did 3 years of internal medicine, graduated that this past year. I'm doing a 1-year quality and patient safety kind of certification through Riverside. And then like Cody said, I'll start pulmonary critical care this July down in University of Louisville.
Yeah, and then as Cody said, I actually graduated 1 year ahead of Zach and Cody. Graduated in 2012. Interviewed with Pikeville. That was my first interview. They typically grant you admission, like acceptance within 48, 72 hours. They also want you to pay, a couple $1,000s to reserve your spot. So essentially parents said, we'll pay it for you, but you have to go there. So, and being down there with that school, they do rolling admissions. So you never know what class you could be a part of. So they originally told me I'd be part of the class of 2017. So I actually signed for a year and taught under Dr. Burns and did a lot of labs and things like that. And then, so then I went to Kentucky down in Pikeville, graduated 2017, matched internal medicine at Doctor's Hospital with Ohio Health, which is on the west side of Columbus, essentially the sister to Zach's institution. and then just underwent another match, if you will, for cardiology fellowship, as Cody Carter already alluded to. After my internal medicine residency, which I'm in currently at the end of my first year, it's a total of 3 years. And I'll finish that in 2020. And I don't know where I'll end up. I know there are some open discussions currently with your guys' home hospital. So you never know. I might end up back down that way. So that's essentially it. We were talking with Abraham setting this meeting up. He kind of wanted us to kind of keep it as a Q&A. So hopefully some of you all have questions on advice with anything, funny stories about Dr. Burns, or anything really. So you guys, Dr. Carter, Dr. Baird, have anything else to add before we jump into that?
Yeah, we'd be happy to answer any questions about the process and getting into medical schools, the like things we use to study, things that you can do right now to put you ahead of the game, kind of things like that. And we can definitely talk about like our path throughout medical school and throughout residency as well, and different sources we've used, how we study. Everyone's a little bit different, but we could certainly tell you like our experience and kind of walking the line. What we did that we liked in the past, what we maybe should have did a little differently. Everyone's a little different.
Give you guys a few seconds to gather your thoughts. If not, I have a question for you two. See if anyone chirps up here. You can submit it in the chat if you don't feel like public speaking is your strong suit. Anything. I'm sorry.
Can everyone hear me?
Yeah.
Yeah.
Okay, good. How did you respectively kind of formulate your portfolio for medical school admission? What are
you're talking about how to
some of
like
the strengths that you relied on personally?
I'm sorry, I missed that last part, Dave. I'm sorry.
Some of the strengths that you have relied on personally, bolster that for your admissions process.
You
guys want to speak up?
Oh yeah, so he's like looking at different strengths and things that they can do right now in pre-med to better like things they can do for like their resume or just like volunteering, things like that. I would think one thing is the MCAT, obviously studying for that, getting ahead of the game and like using their sources and really doing everything you can. I'm not really sure that the test now changed. I think the scoring system's a lot different now. So as far as material, I think at my understanding, I think they added like a social portion of it, or maybe a psych, I can't remember. But so I think the specific study habits might be a little bit different now. But definitely getting ahead like while in undergrad, taking time and looking at different study material and using that and sort of trickle it throughout your undergrad while you're doing your undergrad classes. I think that would be helpful. So the higher score, that's going to be the first like thing that they look to like weed out people. So as long as you hit a base standard, then you're sort of in the game. And then other things that I know they look for like resumes or volunteering, and then little events that people put on. Like I know OU does, they do a lot of events as far as like come here, look, kind of see what we have. This is sort of the things, kind of get to know me things. They used to, COVID's a little different, but I think hopefully it'll be loosen the reins a little bit now. But all these little events, kind of look on their site if you have any connections up there. Find out these little events that they put on and like attending those, getting to know those people, staying in touch with those people, those administration people that are recruiters. That's really helpful. So between studying for the MCAT's number one, I'll put that priority number one. Trickle that with your undergrad material, and then number two, they do like little volunteering things like that. That's nice to have on your resume when you're applying. And then number two, number three, they're kind of the same thing. But and then seeing those events and then kind of attending those, getting your face out there. They have a face to their name, because they just get these pieces of paper that has, you know, a picture of you and this list of, you know, scores and accomplishments. But if you can physically go up there and talk to them, get to know them, it makes it a little bit more personal. I think my biggest recommendation of things that you can do right now to better yourself to increase your chances to get into med school.
Yeah, I would say the same thing. Volunteering is huge. I do know that. I was actually asked about that. What was the other? One thing too, I know the big one that everyone still talks about is organic chemistry. I know the biggest thing is, you know, it's a tougher class, but, you know, say you're, you know, on the biology side of things, you're getting A's and everything, and then all of a sudden, like, organic wants a little bit of adjustment. You get, I'll be honest with you, I think I ended up with I'll be honest, I think I got a C with Dr. Trampy, and my only C ever on organic 1, and then showed the improvement. And I think I either with a B plus A minus the second time. So when it came time for the interview, I mean, they look at that because it sticks out. And of course, I knew they were going to ask about it, but ultimately, you know, they just wanted to see the improvement, and it was literally a 60-second discussion, and they're like, yeah, we definitely saw improvement there, to go from a C to a B plus. Still a black eye on my GPA, that's for sure on that. So then the other big thing is getting involvement with the pre-med club. I can tell you right now, just from being VP with pre-med club when Zach was the president, I believe I ended up talking with one of the recruiters from that would come to Shawnee State. And ultimately, you know, after I got the interview and got accepted, I talked to him a few times, and, you know, he still remembered coming to Portsmouth and meeting me in our in the lecture hall in the library. And he just said, you know, he came back and told them, hey, you know, this is a really outgoing kid. I think he'd fit in here. And he essentially, just from that experience, got me my foot in the door for the interview. So yeah, just the little things. So it's like Cody said, you know, they want to see face with a name, because right, you know, I think even with the pandemic now, this past year, I mean, the applications essentially were up from everything from medical school all the way even where we are in residency and fellowship. So yeah, Zach.
Yeah, no, I can echo a lot of what Cody and Andrew are saying. I mean, really, Shawnee State has a ton of opportunities there, and if I had to say one kind of revolving theme, is just to seek out those opportunities and take advantage of them. As far as building a portfolio, it's everything that Cody and Pollard talked about. You know, obviously we know things like the MCAT and your GPA, they matter. You know, if those aren't some of your strong suits, if those aren't your biggest strengths, then, you know, there's always going to be opportunities to call that out, to kind of explain those things. But, you know, the other things that you can do to surround your portfolio to highlight your strengths are things like volunteerism. And volunteerism doesn't have to be in medicine. You know, it's nice if it is, but I think a lot of what they look at is just that, you know, you volunteered at something, you know, if it's something you're passionate about, you know, even if it's something completely random that you helped build up or volunteer for a dog shelter, or, you know, as long as you were passionate about it and it was something that you were, you know, kind of more actively involved in, I think those things really stand out on an application. You know, a lot of medical schools, they can see, you know, whenever sometimes you went through the motions and did those things, but I think the things that really stand out are those things that you're active in. The other thing, Shawnee has a lot of active research. You know, a lot of times you have to seek it out, and it is something where it's a lot of work, but I think ultimately it's a lot more rewarding. I felt like the research that I did at Shawnee, I had to work harder and to get it done, but I really enjoyed it, and I felt like it meant a lot more to me because of that. And so I know Dr. Burns and I think Dr. Inman's on the call. They're all resources to you guys. You know, they've obviously done this process a lot, reaching back far before Cody or Andrew or I were at Shawnee State. So take advantage of all those resources. You know, there's a lot that goes into a medical school application. There's a lot that goes into your profile, between research, academics, volunteerism, the MCAT. So like I said, the biggest advice that I'd have you guys is just always take advantage of opportunities. I think if you don't ask about it or you don't reach out to someone about it, then you're not going to know. And just like Pollard said, and Cody talked about, these little events that medical schools do, be looking out for that. If you're looking to apply to a specific medical school and you have one that you're really interested in, or a couple that you're really interested in, look to see if they do any events for undergrad students throughout the year. And when you get that opportunity, go network, talk with people that are in that school. Those little events are big. And a lot of times there's a lot of schools that keep track of those things. You put your name down on a piece of paper that you were there. And when it comes up to an interview time, you're talking about it. And, that gives you something that really puts your specific interest in that program kind of at the forefront. And programs really like to see that you were involved in their program. They want to know that you want them as much as they want you. That's really nice for them to hear. So.
Take another question.
Yeah. Can you guys hear me?
Absolutely.
Yeah.
I mean, so obviously you guys are DOs. I was going to ask you about the OMM. Do you guys currently use it in your practice? Do you think it is worth it? Or do you think that a couple hundred hours of training would be better suited for preparing for step one?
You guys want to take this? I
Yeah.
can take it.
Yeah, you got it, Zach.
Yeah. So I would say that that's entirely dependent on the person. I do not personally use OMM currently in my practice. I think, I went to ACGME residency. And so I don't exclude the possibility of being able to use it in the future. But I would say that it's a lot of person to person dependent. There were people that I went through in residency that continued to use it far after medical school. I would say that the training that I got in it was absolutely useful. I have a large anatomy background, so a lot of the OMT training was a lot of anatomy based training. So I really enjoyed it. And I think I still use those principles more at home than I do in my job, but I still use them. So I would say that those weren't by any means wasted hours. But like I said, I don't personally use it job wise right now.
Yeah, I would kind of agree with that. It's definitely not wasted. I don't really use it a whole lot now, but I know a lot of people in my class, my residency class, they will. Some of them, they love it. And like our clinic, whenever we see our outpatient patients, they'll schedule up specific OMM visits, and they're fantastic. It's great. I really use it a lot, and like it's definitely not wasted too, because if you go into medicine or even surgery, whenever they're teaching you like the OMM curriculum at Athens and then anywhere really, they focus on anatomy, and anatomy is the structure and foundation of everything. So if you're going into surgical specialties, you're learning anatomy in your OMM lectures. So the OMM lectures, it's not way, even if you don't use it like in a day-to-day, the things that you learn from it will help you some way or another. Either your medical understanding of why this person's having this pain, in their right shoulder or whatever, or surgery. You're in a belly, and you're looking at different connections and ganglia and why they're experiencing pain in these ways. So that's great. And like my day-to-day, really, I really like kind of use it with, my girlfriend or my dad will make me do it sometimes, and he's got a bad back or something. But I don't really use it in my patients as much as I should.
Yeah, I would say the same along with Zach. Person to person, variability definitely. Also, depending on what your specialty you are in. Obviously, cardiology. I'm not going to be, fixing someone's leg pain or back pain. So, not much, at least for me, utility for me in my training currently. So, I think it'd be useful, if you wanted to focus on primary care. It does give you another tool in your tool belt, so to speak. If you're a family physician in private practice, especially unfortunately, in Ohio with the opiate pandemic, it does, it does give you another, like I said, another tool in your tool belt. So rather than prescribe some type of pharmacologic to treat someone's pain, so
Yeah, I've always thought it'd be best to use the sports med and like dealing with sports teams or primary care physician. Those two settings, I feel like it'd be perfect.
I know one of our friends that when we graduated from Shawnee State, he went to Virginia Tech, and I know their team physician is a DO. Edward Villa is the med school there, and I know their football team actually used the medical students and everything, and they actually treated them, treated the football players. So, like I said, it just depends on what specialty you want to go into. As far as I think you were saying too, you were worried about like, the extra 100 or 200 hours of the actual class time and lab time affecting your step one studying time. That doesn't really affect you too much. I mean,
Yeah.
we all did really
Yeah,
well.
no,
Step one,
thanks, Bailey.
like the actual class hours there. On the bell curve, they give you your overall score, and I can tell you, us three did just fine compared to the national average against the allopathic students. So.
I would echo that.
Yeah.
All right, thank you.
Mhm.
I was going to also ask, did you guys perform any research in, medical school?
And did you get? I could take it. I did not actually. So med school is it's pretty tough. There's usually at least at Kentucky. It was like between first and second year. You would actually do like a research fellowship, so to speak. They give you a little stipend, and that'd be the only time that you'd really have time to actually do research. I know there was some students in my class, they would just like collect data at the hospital, but I chose to focus on actual on my studies. And I didn't really get asked too much, at least in internal medicine residency, about research in medical school. Zach, did you guys get asked about your research experiences in medical school? I don't really remember that coming up.
Yeah, and that's a good point. I'll let Cody take it away here in a second, because I know he did a little more research than I did, but I didn't do any. So in medical school, first and second year, you guys probably already know this, but your first and second year are your kind of like PowerPoint. It's more of just like lecture based. And then, your third and fourth year, your clinical years. So like Pollard said, OU did a similar thing. In your first and second year, you have an option to do like a summer research opportunity. I didn't take advantage of any of those, but in my third and fourth year, when I was on my clinical, at my clinical site, I did clinical research with one of our ER docs at SOMC. And so those, again, are just opportunities that you have to seek out. And it did come up on my, during my interview process. They asked about, because obviously when you submit your residency application, your ARIS, they have specifics about research and everything. So they'll ask about it if it's on there. And if you're wanting a more competitive specialty, you certainly need to make sure that you have that on there. I would say that, definitely take your first year of medical school to just kind of get your bearings. Don't think that you have to come out of the gate swinging. You can always get your bearings together, find out if your medical school has any research opportunities, get into that toward the end of your first year, into your second year. And then whenever you get to your clinical sites, when you start doing clinical work your third and fourth year, find something clinically that you're interested in and do research in that. And that's what I did do. I think I did mine on like SVT in the emergency department, but you could really do it on anything. Some specialties like you to do research more based in that specialty. But a lot of places, they really just want to see that you've done research, that you have went through the scientific method, that you know how to put together a research project, that you know how to submit an IRB report. The value is really in those things, knowing how to do research more so than what you did your research on sometimes. Cody, I'll let you take it.
Yeah, I'd agree. That's definitely what they want to see. I did the in between the first and second year, it was like your last summer off. I chose to do one of those summer research opportunities. I went to Grant and did some research with trauma surgery. It was really cool. It was a really good experience. I was busy a lot, but between like first and second year med student, you really don't know anything. Really, I don't have a lot of family people like in medicine, so I didn't know how a hospital worked, just the ins and outs. But gave me the opportunity to get my foot in the door. I would help out like the trauma bays coming to Grant. They're like a mecca trauma center up here. And I would help out with the traumas and kind of get my foot in the door and little things like that. And I would also do some research on the side. And I did that my first year. And they flew me down to Jacksonville to do a presentation on one of these, it was a surgery thing. So they did, just presented at this conference. And my third and fourth year, I picked up another project for ortho trauma. And then that got published. But that was more, that was just kind of on the side. I didn't like come up, and I wasn't like in the trauma bays or seeing ortho patients or anything like that. That was just sort of kind of, I would, through med school, you can pick up one research project if you'd like, if you're trying to do something a little bit more competitive. But once you're kind of in residency, depending on what you want to do, if you want to do something like a fellowship, I'd probably recommend maybe picking up one smaller like case report per year. Case reports are, subspecialties of the research that are a little bit quicker to do. The value of doing those retrospective studies is going through IRB approval, walking that line, then getting rejected, waiting 3 months, and then it's a long process. So definitely, whenever you pick up and you commit to one of those research projects, it's going to be a year or two to do this whole thing. But going through those motions, definitely you learn a lot from it. And then, getting that Excel document, have all these MRN numbers for all these patients, and getting all this data collection. And I think they, as a fellowship or an academic center specifically, as opposed to community centers, whenever you're looking for residencies, academic centers, they want to see that you've been through you've dealt with the IRB people, you've at least walked the line, and you've done it before. So if you want to go to an academic center, I would definitely recommend it, picking up one project throughout your med school. And then while you're in residency, I would recommend maybe a case report a year if you're wanting to do an academic center or even a bigger fellowship. That being said, you don't have to. Community programs are focused more on treating patients and doing, and then just helping the community out. When all is said and done, I probably won't do a whole lot of research, but now I'm pretty involved in research and have a couple of studies now, but really just kind of just doing it to sort of do it. Now I've done it so much, I'm starting to like it. So I started off not really liking it, and I'm just like, I'm just going through this process, but now did so much, you start to get the hang of things, and you're like, oh, I actually know how to do this now. And you start to get some, upcoming med students that are wanting to get involved as well, and interns and people below. You're like, oh, I'll help out with this, and you show them how to do it. So it's kind of something that I started off not really liking, but then now I'm kind of going through it, and I've done it so many times, I'm getting the hang of it now, and now you'd be surprised.
Yeah. I think the general progression is that in medical school, most people did more research going into kind of their clinical years, their third and fourth years of medical school. Obviously, some people, will get caught up and do research toward the end of their first year and into their second year, and that's totally fine. You apply during your fourth year. So sometimes if you want the research on your application, like I said, if you're applying to one of those more competitive specialties, you'll start doing it into your second and third year of medical school. Just one of those things to kind of think about during your first year of medical school, kind of formulate your ideas, figure out who it is that's doing research and what they're doing research in. And then when something kind of strikes your fancy, during your second and third year, go for it.
I don't know if you guys were finished with that one, but I have another question.
Yeah.
All right. What kind of demographics with patients do you normally see in your field?
Cody and I Cody's training at the program I went through, which is on the west side of Columbus. It's actually really, really diverse. From the west side of Columbus, we get, truthfully, it's more a poor socioeconomic demographic.
We have Somali population as well, and
So, yeah,
I feel like we had,
Columbus, Ohio, is home to the second largest Somali refugee population in the country, I believe, outside of Minneapolis, Minnesota. So large Hispanic population as well. Large, I think it's from Burma, at least on the west side of Columbus, we get a lot of, so it's really, really, Columbus is a really nice place to train. If you want to treat a very, very diverse patient population, which which actually is really important, at least in cardiology, as far as like, there's a difference with treating hypertension in Caucasian and African Americans. So, but yeah.
Yeah, I'd echo that. Even at Riverside, the demographics were kind of all over the place. I mean, I would say they're right. At Doctor's Hospital is probably on the west side, maybe a little more of an indigent population, but we took a lot of transfers from all around the state, and so we got very, very diverse demographics. So.
Yeah, I think having like training in an area or like a lower socioeconomic class is a lot of those really rare things that you've learned about, and you're like, I'll never see that again. And I feel like I swear they're always in like IV drug users or something like that. And I don't know what the incidence of neck fash is, but I don't know, if you look it up, it was really low. And I swear I saw like 5 in 1 month, and I'm just like, this has got to be like biased. But working in that area around doctors on the west side of the hospital, it's definitely good training. You see a lot of really rare things. So that's something to keep in mind whenever you're picking different places, as opposed to being like in Dublin, which is a little bit more upscale place. The patients are much more educated, which is great. But training in an area of lower socioeconomic class, I think you'll see a lot more rare things. You guys have any other questions?
Yeah, keep them coming. These are good questions.
Cody, Zach, I have a question.
What's up?
Hey, if you guys had to do it over again, what's one thing that you would have did different at your time and during your pre-med years, getting ready for medical school?
I think probably it goes back to what Cody said too, is I probably would have taken more time just throughout, like my 2 or 3 years before I took the MCAT, just kind of developing more of a study plan, doing a little bit more studying around that. And then I probably would have done a little bit more research too, just in getting used to submitting it to, if not more types of research. I think sometimes it's important to stick to one project that you're very invested in. But I probably would have taken that project and submitted it to more places, because now knowing what I know, a lot of times it's just about taking that research and seeing where it goes. You can submit it to all kinds of different conferences and things like that. And those things are really valuable to go to. And then definitely, like I said, just kind of peppering out the MCAT studying throughout my 2-3 years and kind of having a more developed plan for that.
Yeah, I think I would have definitely done that. I would have taken a little bit of MCAT study material specifically for that exam, and I would have done a little bit throughout each year, and then progressively more and more until your 3rd year. And I think because a lot of things on that exam, there's some little nooks and crannies. So now I think there's a sociology portion on it now, right? So I mean, it's going to force you to look at their material and look over that material, even though we all did really well throughout all my courses and things like that and got a good GPA, but some things that are specific to that exam that you're only going to pick up if you just look at that, whatever their study material is. So I would have trickled a little bit more material through that, through the MCAT. And like Zach said, I probably would have picked up another research project or two, got a little bit more involved, maybe presented, maybe went to a conference or two, and kind of, I would have done that a little bit differently.
Yeah, because the actual preparing for medical school, I feel like Shawnee does that, 10 times over. I felt like medical school was really not all that challenging, especially after the curriculum at Shawnee State. I know a lot of people would probably say that, would be like, I probably would have prepared this a little bit better for medical school. But from that standpoint, Shawnee State prepared me more than enough for medical school.
Yeah, after you get in, you're great. Like I said, the compliment cascade, you learn that it's nothing like in that med school. Like it's the pictures that you have to draw that Dr. Baird says you draw, they're super, and which is awesome. You give you that solid foundation that you will have, and you'll have it way better than your colleagues. And it's just the MCAT is just a hurdle that you have to get through. And if you don't specifically look at that, the trickle a little bit of their material, very doable. But once you cross that hurdle in med school, you'll be great. The education you get from Shawnee is fantastic, and it's absolutely sets you up for success. Just hitting that hurdle.
Yeah, I would echo the same thing. I think it all comes down for the MCAT is getting used to taking standardized examinations and knowing what I know now from taking all these different national board certification exams would be finding a question bank and just doing questions.
Yeah.
You know, read their material, do their little courses or whatever, but it's all comes down to getting used to how their writing style is for those questions and just doing repetition. Because essentially now for all of our board exams, I hardly ever actually read actual true text. I just do their questions and read their actual explanations. Knowing what I know now, that's what I would have did different. I agree on the research, definitely should have done more of that. And then I can definitely echo, there is one thing, I was kind of a binge studier. I know Dr. Burns wouldn't want to hear that, but developing healthy, Zach lived with me, Cody lived with me, this is not what you want to do, but I wouldn't, Dr. Burns, close your ears. But I really wouldn't look at anything until a night before a quiz or even a day. I've studied 24 hours straight for your exams. And going into medical school, that's not going to cut it. You have to do a little bit every day. 2, 3, 4, 5, 6, 7 hours, whatever it is. It's basically 2 full-time jobs essentially. Depending on what school you go to, they either expect you to be in class, Pikeville, mandatory attendance. I don't know what it is like now, but you had to be there. They would take attendance for every class. And then, depending on, how your grades and stuff were, they would, crack down on it. But, so that's 7, 8 hours. Then, you know what? You have 7, 8 hours material and you better be studying that material for 7, 8 hours. So there's your two full-time jobs. And then guess what? The next day, another 7, 8 hours of material again. So it just never stops, but definitely doable. I would say from my time at Shawnee, I would say my first year was essentially at Pikeville was totally review. So that definitely helped things. I will say, knowing how Dr. Burns taught immunology, of course, I was an anxious guy. I would sit in my head going, I know how they can ask this question. They can make this as hard as they want. And of course, the people in my class had no idea. And of course, when the exam came, I'm like, this is immunology 101 compared to what Dr. Burns put us through. Of course, unfortunately, Dr. Burns, there are no pictures in medical school.
Yeah, and then the education through Shawnee, I didn't fail a single test in med school, so it was good.
Yeah, we rock it. Shawnee State.
I like what Andrew said though about developing those habits early. When you're at Shawnee, because you're going to be taking standardized tests from here to the end of your career. I mean, I think all of us are going to, in the end, be triple board certified and have to take 3 different board certifications every few years. So the standardized tests are never going away, and so developing those habits now. And like you said, studying a little bit every day and just kind of getting used to that flow would definitely have been helpful too. So.
Definitely. I mean, I actually knew personally, a close friend of mine, he got through medical school, but he got behind early because he thought he could study like he did in undergrad, basically study, put off 2-3 weeks of material, study for a week and, let the chips fall where they may. And he got behind after the first exam, failed a couple different courses that first exam, and he played catch up from then on out. And he really never truthfully caught up until end of year 2. He was behind the 8 ball the whole time. So definitely, learn good study habits. It's never too late to learn. So.
Yeah, these are good questions. You guys have any other questions?
Hi, we can hear you.
Hold on. My girlfriend's on with her friends.
Oh, that's Al.
Okay, I'll jump in with a question then, since other people aren't asking right now, but can you kind of tell people about maybe a day in a life? What are things like for you now and back when you were a medical student?
Yeah. Zach, you want to go or do you want me to go?
Yeah, sure. I can take it first. The first couple years of medical school, like I said, are just kind of brute force. PowerPoints, lectures, exams. I know medical schools will have a couple different tracks. I know Corey Johnson, if he were here, he had a very different experience in medical school. He did more of a small group approach, where they did a lot of case-based learning and small group learning. And I know some medical schools do that. I chose the more traditional route. So, at OU, it was every morning, 3 to 4 hours, you had lecture. And then if it was a Tuesday or a Thursday in the afternoon, we would do small group learning where we would go through cases. And then we would learn like diagnostics, how to run labs, what they mean. And so we do case-based learning. And then, every 3 or 4 weeks, it was exam week. And that week you'd just be studying all week long for the block exams. And so that was really about it. I would get done at lecture about noon. I would go home. And if it wasn't a day where I had stuff to do in the afternoon, like on Tuesdays and Thursdays, if it was Monday, Wednesday, Friday, I would spend the next 4 hours just kind of reviewing the PowerPoints that we had that day, making sure that I got everything down, and that, just kind of get a second look at everything. And so that was really, the first 2 years. And then third and fourth year are very different. You're on rotations in the hospital. You're actually kind of learning how the hospital works. And so, depending on what rotation you were on, you get there first thing in the morning, you'd be there till 4 or 5 p.m. every day. Sometimes it would be, you'd have to go in on weekends. But, a lot of times if you're in an office-based setting, they don't work on the weekends. So you had your weekends free. And it was kind of nice because you didn't really have to study for a whole lot of stuff like you did your first and second year. At the end of each rotation, you have these exams that you would take for your core kind of rotations, family medicine, pediatrics. They would have you do an exam over those. So that was really, the day in the life in third and fourth year was kind of just like normal, go to work, go to the hospital, come home. It was much nicer than first and second year. First and second year, even when you're done, you always feel like there's something more you could be studying. And then residency is very different. So especially in internal medicine, that was about 6 days a week, typically. And you'd get there at 6 a.m. You'd leave at about 6 p.m. at night. And then you just did that for 3 years. I don't really know what else to say. It's a lot of work. You just get used to that kind of a schedule. This year, when I did the Quality and Patient Safety Fellowship, the certification, I work 1 week every like 3 or 4 weeks on an internal medicine service. The rest of the time I'm in WebEx meetings. So it's very different. And I'll be honest with you, it took a lot of adjusting, not being in the hospital for 60, 70, 80 hours a week. But yeah.
Yeah. Pikeville, of course, Zach and Cody went to OU. Pikeville's a little bit different. I'm trying to remember when class started. I feel like it's forever ago. It was either 7 or 8 a.m. And then they would go till noon, one after another, each class. And then noon, they'd break for lunch for about an hour, and then you'd regroup, and you'd come back usually around 1 to 3:30 or 4. And then essentially at that time, I would actually go to the Y, work out, come back, eat dinner, and then I'd actually go back to the lecture hall in my actual same seat. And I was a little more intense. I would study probably from 8 p.m. till about 2 a.m. I know that sounds crazy, but that's what I did. And then I'd rinse and repeat, Monday to Friday. Friday nights was my, I would actually not do anything as long as there was an exam the following week. Friday night, when class let out, that was my one free night that I let myself have. And then Saturdays, get up. I would study at around, maybe sleep in a little bit, probably start around 9 or even 10. I'd study till 5 or 6 p.m. again, take the night off on Saturday, and then Sunday do it again, and then Monday go to class. And essentially that's just what you do in your first and second year. And then Pikeville was actually kind of nice. Every 4 weeks was a block exam setting, covering 5, 6, 7 different courses or whatever. And then, so actually about 3 or 4 days before the block exam, we had no classes, which actually made it quite nice. So I would just literally go crazy and study for about 19 hours a day until the block exam. Well, that's what you just have to do. Again, medical school's doable. It's just, just takes a lot of perseverance. You get through the pre-med club at Shawnee, you won't have any issue. Okay. But then move on to residency, same as Zach said, you're in the hospital, usually around 6:30 in the morning. Usually our didactics. So didactics are just a lecture. We'd go over interesting cases or whatever. You'd have another physician come in and give you a lecture from 7 to 8:30. And then you would go see your patients, and then you round. And we're all internal medicine, so you round, on the patients that you have, and then take new admissions or whatever. And then, like Zach said, get out of there at 5 or 6. It just depends on what service you're on. Internal medicine or the hospitalist service, you round on patients on general floors, and then you have, your intensive care rotations that are, a month at a time. Those could be your longer days. During COVID, was interesting. Usually days started around 6 or 7 in the morning, and I would not leave till Cody would be my night help. Cody would come in at night to relieve me when we would do 7 days straight. I would leave about 11 or midnight, and the same thing the following morning. He would stay till noon. So crazy long hours. It's just what had to be done. But yeah, it's just a lot of work, but it's totally doable. I mean, I will say this: a 60-hour work week in residency is a light work week. 60 hours is nothing. On average, is probably, what do you think you worked on average, Zach, a week on a normal rotation? You think what, 60 to 70? Yeah. You're muted, buddy.
Yeah, it was about that. And I think, like you said, it's important because during medical school, first and second year, even when Friday, the last day of classes was out, definitely take a day where you just kind of relax, where you don't look at anything, you don't look at a PowerPoint. And the same thing goes true for residency. Even if that one day that you get off in the week or whatever, or if you get a whole weekend off, just take it away, do something that you enjoy. A lot of people that we know, they hike, they bike, they, do something. But just kind of take yourself away from all of it. And I think that's really important. That's what's kept us, I think, very sane through the years, is just having an outlet and making sure that you take that time for yourself. I think that was one thing I didn't mention when I was talking, was that we studied over the weekend. That was your kind of time to catch up and review the PowerPoints from over the week. But I would always take one day where I didn't look at anything.
Yeah, I have to echo a little bit of that. And I tell everybody, just like Pollard said, is anybody can make it through med school. Anybody. You don't have to be wicked smart or anything like that. The education that you get from Shawnee is fantastic, and you'll get that, and you'll do just fine. Just cross that hurdle with an MCAT, and then go through it. It's just busy. You put the time in, you'll do just fine. It's just getting in. And then through residency, I mean, the education continues. Like, we do didactics, which is like our study time twice a day, every day, for 5 days in a week. If you're on an all-service rotation, you don't have to attend. We can do WebEx and Zoom and stuff like that, and still catch up lectures. But so it's twice a day that your medication, your education is it's ongoing, and it never stops, which is great. It's one of the best things about medicine. Things change all the time. Like everything, cardiology is one of the most well-studied fields, and it's changing like all the time. The lipid guidelines, compared to the Europeans, it's all a little different, and we usually lag behind a little bit, but but the education you'll get from Shawnee is fantastic. And yeah, I think you guys will do just fine.
I guess I could speak on the fact of fellowship, since I'm currently in fellowship, similar to residency. and a little bit more responsibility though. So Cody would still technically, I mean, he's technically still a resident. So if he's on a cardiology service, the hierarchy essentially goes from intern, which is your first year of whatever specialty you're in, and then you have your then you become a resident essentially, which is what Cody is now. And then usually there's depending on what service you're on, but if you're on a cardiology service, I'll be the fellow, and then you have an attending. So, and then the attendings at that point kind of expect me to essentially see all the patients, come up with all the plans, and the attendings are just there basically for me to run rounds when you're seeing the patients and come up with the plan, and then the attending will chime in. So a little more responsibility. Hours are, I would say, similar, but it would just depend on what program you go to. Just more responsibility and fellowship. Yeah. Anybody have any other questions?
Why did you choose medical school versus a physician assistant program? So the question in the chat, did you guys see it? It says, not here earlier, it's from Laura, but why did you choose medical school versus physician assistant or one of the other advanced practicing provider programs?
It's a good question. I don't know if I have a really good answer for that. I know since I was, 4 or 5 years old, I always wanted to be a physician, but I also think it comes down to, unfortunately, I always had to see an ear, nose, and throat doctor. So I was always once a month as a kid, always seeing them. So I think they made an impression on me. So I think that's kind of why I chose it. I don't think you could go wrong with either profession, to be honest with you. But I don't really have a good answer for that. Maybe Dr. Baird or Dr. Carter can speak to it.
Yeah, I mean, that's a great question, Laura, and I think it's something that we all considered. I think when we were going through Shawnee, we had a lot of our friends went off and did physician assistant. Shane works at SOMC now, and so, I mean, really, it just kind of comes down to what you want your practice to look like. Physician assistants, they do a lot of the things that physicians do. A lot of times they're still reporting to a physician. I know we have physician assistants that work in the ICU. They still report to the attending physician that's there. So if it's more autonomy that you want to kind of make those decisions, be kind of the final decision maker, that may push you to go to medical school one versus the other. If you want more freedom to kind of go into whatever specialty you want or change specialties, then doing physician assistant is a fantastic idea. The physician assistants I know, my internet connection's unstable. Can you guys still hear me okay?
Yeah.
Can you still hear me? Okay, all right, good. Said it was unstable. So yeah, that may push you one way or another. For me, I think it just came down to, I really loved, kind of all the different parts of medicine. And that's why I went into internal medicine, and I just felt like going to medical school, I was going to get kind of everything that I wanted, as far as going as far as I possibly could into understanding all of those mechanisms, from pharmacology to anatomy to physiology. Not to say that physician assistant programs don't study all of those things, but for me, it just seemed like the path that more suited what I wanted.
Yeah, I'd agree. I think the biggest differences between those two are autonomy, and the dedication. Really, I feel like the PA really gives you the opportunity to kind of switch. I feel like you have a little bit more, I don't say freedom, but if you want to change fields, you can change fields pretty quick. But from a physician standpoint, once you're in internal medicine, I mean, you can, don't get me wrong, but it's just a little bit more difficult. You like, if it's surgeon to internal medicine, for instance, it's a whole different lane. Once you go through med school, a lot of different surgical specialties, you either go through general surgery first, like internal medicine, and then you do cardiology, GI, nephrology, whatever we're here, or like general surgery, and then you do cardiothoracic surgery, vascular surgery, trauma surgery, things like that. So if you do internal medicine and then become a cardiologist, it's you can't really like switch and go work as like any like surgical specialties at all. You have to go through the whole thing to really be a surgeon. But PA system, you can kind of change things around if you don't like the scenery. So there are advantages and disadvantages of both. Again, I don't have to, like being a physician, you are the end of the line, like Zach was saying. You end up making the final decision what's best for the patient. But everywhere is a little bit different. So there's a lot of gray area in there. But I think in general, that's probably the biggest differences between the two. And yeah, but PA is a fantastic profession as well.
We all work closely with physician assistants, and you will, no matter what field you go into. If you go through medical school, you become a physician, you're going to be working with nurse practitioners, physician assistants. Same thing if you're a physician assistant, you're going to be working closely with a physician. So you kind of, we all work together to accomplish the common goal. It's a good question, Laura.
Does anyone else have any questions?
Yeah, I was going to ask, so why do you guys choose internal medicine? Did you want the, breadth of knowledge of kind of like every field, or you didn't enjoy peds or OB, or did you just know the subspecialty like that you wanted to go in specifically?
At least for me, I'm always the person, I'm always unsure of what I want to do. So truthfully, I liked neurology when I was at Shawnee. So I really thought I was going to go in like a neurology residency, but did a neurology rotation and knew. And then I was like, well, maybe I'll do surgery. And I'm like, and then I start thinking about it. I get frustrated putting Legos together. So I'm like, I can only imagine getting called in the middle of the night. So third and fourth year, getting called in as a student at SOMC, I'm like, I can only imagine doing this on my own. So I'm like, this is going to be out. So essentially it came down to, going in internal medicine. It then gives you more avenues, another 3 years essentially to figure out, is there any other subspecialty you want to go to? So if you do internal medicine, you go to gastroenterology, cardiology, pulmonology, critical care, hematology, oncology. So there's essentially more avenues as far as subspecialties to go. But for me, it essentially came down to the fact that I couldn't really see myself doing any of the other specialties right out of medical school, like OB-GYN or surgery or anything like that. So that's essentially why I chose internal medicine. Just essentially gave me more time and gave me more avenues to see if I wanted to subspecialize. And then the other thing is too, I just enjoyed essentially all the organ systems, so to speak. But yeah, maybe the other guys can speak to it.
No, I totally agree with Andrew on that one. I think the breadth of knowledge that's required for internal medicine is really what drew me to it. Internal medicine, I worked with an internist my third year. It was one of my first rotations. And just the kind of analytical thinking that they do, and just kind of the in-depth, physiology, pathophysiology, and the breadth of different diseases that you see is what drew me to it. Just because, like Andrew said, I loved every organ system. I was that person that went through med school and nothing really struck me. No one particular thing. I loved all of it. And then, you kind of learn early on, do I like being in the hospital or do I like more outpatient medicine? Internal medicine offers both, but I definitely saw myself as more of an in-hospital kind of person. And then, the next branch point is, do I want to be in a surgical type specialty or more medical? And like Andrew said, I hated when I was on surgery, and I hated my OB rotation. They're all great specialties, but you kind of, during your third and fourth year, you kind of find your niche. And for me, it was just, I loved medicine, just plain and simple. And then the specializing part, I kind of decided on pulmonary critical care shortly after I decided on internal medicine. And so, even though I'm going to specialize, I still picked a specialty where I'm going to see a lot of different disease. And yeah.
Yeah, for me, I initially actually was interested in surgery. I like the idea of like doing my research thing up in Grant and hanging out in the trauma bays. I like the idea of trauma surgery. There's a lot of aspects about surgery and training. I feel like they always end up getting work. They always work out of all the residencies and things. General surgeons, they always get them. They work the most. Their hours they're more brutal, and I think that some of the personalities are pretty strong sometimes in the OR, and they end up doing a traditional internship where you kind of rotate everywhere. And from there, it's just I really like internal medicine, and some things that whenever you branch, you make the decision, and it's usually either surgery or medicine. And then a lot of things that you do whenever you go the surgical route, I feel like there's a foundation there that you're just missing. Whenever you're taking care of patients, you immediately come out of med school, and I have no knowledge of like really like how a hospital works. Like I said, I don't have any family members and that I can look up to that know anything about how like they're doctors or they know how hospitals work. But being in internal medicine gives you the fundamental knowledge of how hospitals work, how people come in and go out, outpatient and inpatient setting. And then from there, I like procedures. So you can do, pulmonary critical care, GI, cardiology. They all have, interventional cardiology is what I'm interested in. Procedures, you can get that fundamental knowledge, understand how hospitals work in an outpatient setting, and you still have the freedom. You're not stuck doing this one thing of doing all of these different branches. You can do all outpatient if you want. You can do outpatient endo if you want. You can do nephrology. You can do inpatient or outpatient of that, and you have a lot more flexibility, and you have the foundation. And that's why I like internal medicine.
And for those of you guys that don't know, in case there's anybody in this chat that is unfamiliar, when we talk about subspecializing internal medicine, you have to do internal medicine to do some of these specialties. So things like cardiology, hematology and oncology, gastroenterology, you hear about all these specialists, but they all had to do internal medicine first. So internal medicine is kind of the branch point that then, feeds out into these different specialties. You have to do internal medicine first. Not every specialty is like that. But for gastroenterology, pulmonary critical care, cardiology, you have to go through internal medicine first, just in case anybody did not know that.
Thank you.
Yeah.
Absolutely.
Colton, I jumped in kind of late, so I don't know if this was asked yet, but it's my understanding that DOs have extra courses to complete versus MDs. But what's the difference between the two, and does it make a difference to have one versus the other once you get out of school? That's a great question. Comes up all the time. I can go ahead and just kind of start it off, and then Cody and Andrew can expand on it. But yeah, so essentially, during when you go to a doctorate of osteopathy, when you go to a DO medical school, there is about 200 extra hours during your first and second year that you spend doing what they call osteopathic manipulative medicine, OMM. Some people call it OMT, where the focus of it is more on kind of aligning structure and function. You focus in on the muscles and the bones and how those structures and kind of interplay with disease, whether that be pain, lymphatic drainage, blood flow, and you kind of use these manipulations and these ways of manipulating the muscles in the spine to kind of get things to work again or to reduce pain. And so that's really the extra courses that you complete. And then when you get out, some people, like we were talking about earlier in the talk, will choose to continue that as part of their practice. I would say it's much more common for outpatient primary care physicians, to kind of carry that on and do that more. Sports medicine physicians do a ton of OMT and OMM. But really the differences between the two, once you get out of school, like for what me and Cody and Andrew are going into, there would be no difference between a DO and an MD. We get the same training. We go through the same residencies. I did my residency with a mix of DOs and MDs. So after that branch point, really the residency training is the same. And if you as a DO wanted to make OMM part of your everyday practice, even if you became an obstetrician and you used it on some of your patients during pregnancy, that's totally up to you. I think that DO schools, at least from my perspective, and I might be a little bit biased because I went through an osteopathic medical school, but I felt like it for those that wanted to use it, it gave them an extra tool in their tool belt. It's just something that they make it a part of their practice, and they still use it. But essentially, as far as the training goes, after that, no difference.
Yeah, I would agree. And it's really, I feel like all the advantages in the DO schools because you get extra training. It's an extra thing. So whenever you're taking your boards, you'll take the first two, so you take really 2 steps while you're in med school. I took the MD steps and the DO steps and did, the same on both. So you just have, whenever you graduate from a DO school, you just have an extra thing. So you have the same test scores or the same boards that all the MDs pass, and you have, in addition, you can do OMT, which they don't know how to do. So I think whether you go on to use it in your practice, that's completely up to you. Like they're saying, from doing interventional cardiology, you're probably not going to use it a whole lot, to be honest with you, but it's fantastic. It's only in the advantage of having that extra knowledge. And then throughout the training, you just learn a little bit more of anatomy. So you can take that knowledge of anatomy and do, it's not wasted knowledge, that's for sure. Other people in my class, they love it. Absolutely love it. But that's a good question.
Then in regards, if you're wondering about actual knowledge base from allopathic to osteopathic, at least being a fellow, I've worked with both MD interns, osteopathic interns, and they're all just very naive interns. No intern essentially from either allopathic or osteopathic know more than another. And then Zach, as you know, being at Riverside, I've never had an allopathic physician there ever bring up the fact that my DO ever.
No.
The electrophysiologist I was just working with last week, he trained at Vanderbilt and then Harvard for his EP fellowship. So never talked down to me or anything like that. So
yeah, same. Even when I was interested in surgery, doing surgery rotations, that whole DOMD thing it's really not there.
Yeah,
they're the same boards now.
That's it.
And now too, the match is all the same too. So before you had an osteopathic and an allopathic match, where the DOs would, if you wanted to do an MD residency, you had to forego the osteopathic match and to do the allopathic. Now it's all just one match. MDs can go to DO residencies, DOs go to MD residencies. Well, DOs were always going to MD residencies. That's been a thing, for a long time, but now even the reverse is true. So now it's all just one match. So, the line, even that faint line that existed before is now completely gone. So as far as differences go. These are all great questions, by the way.
I was going to ask, so step 1 went to pass or fail. How do you think that could affect the match?
That is a great question.
That's a great question.
And I think a lot of programs are asking themselves that, they're really, programs I think are always going to try to find an objective way to put people on the same playing field. So does that mean that now step 2 is going to have more weight behind it since it's still a scored numerical exam? I think that it's overall a great thing because step 1, and what he's talking about for those that don't know is, but after your second year of medical school, you take your first step board exam. Through medical school, you have to take 3 board exams to technically be done with, to technically be done with medical school. You take your 3rd during residency. So you still get to graduate before you've taken your 3rd step. But the first step board exam happens after your 2nd year of medical school before you go into your clinical years. And so, now that that's a pass fail, I think it's great because step 1, I think a lot of people see as, it's just this really formality of an exam. It goes through, really basic science questions like biochemical pathways, things that don't equate to anything that makes a good physician. So I think a lot of people used to think that, well, having so much weight on a number for an exam that doesn't really, test how good of a physician you're going to be. I mean, why do we make that the standard for what residency you get into or how competitive you are when you're applying for residency? So I think from a lot of respects, it's a good thing, but how programs are now going to, how they're going to equate people, as far as, I think it's number one, I think it's probably going to move to putting more weight on step 2. And then some of these other parts of your profile, like we talked about earlier, some of these other things in your application are going to become more important, such as your evaluations on your rotations and how you do in your 3rd and 4th year of medical school. But that's a great question. I think everybody's guessing at this point.
Yeah, I'd agree. I think just like Zach said, I think step 2 is probably going to have a little bit more weight, and step 2 is honestly a little bit more realistic anyway. It's a lot more like, what is the next best? Like, this patient presents to you these symptoms, you find this on exam. What is the next best step? What is the most appropriate next step in management of these patients? As opposed to step 1, it's like, what enzyme in the Krebs cycle is blocked by this particular disease or something like that. So it's a little bit more memorization, regurgitation, but then step 2 is a little bit more real life, clinical based anyway. So I think that at least from a program standpoint, they're probably going to weight step 2 a little heavier, and then all those extra other little things in your resume will probably kind of speak up a little bit more once they have that pass or fail on their step 1. And again, like if you guys do, like, I'm a pretty outdoorsy person, so if you guys do some like cool outdoor events, I recommend like putting those on your CVs down as like other. If you have, like, some people like do these huge long hikes, like part of the Appalachian Trail or whatever, all these little accomplishments, those things stick out whenever you're interviewing people. And after going through the process, being where you guys are through med school and residency, and now I'm interviewing students or doing this whole thing, and I kind of look at those things like, oh, that's cool, this guy is a snowboarder or whatever. I think it's a conversational piece. So throw those little things in there in the bottom that might help you out a little bit in an interview. But I definitely think that all the other things are going to be a little bit more highlighted.
That's a great point, Cody. I actually wanted to bring that up earlier. You have to have some type of unique fact or something that sticks out. Because in my medical class, school class, we had kids we had a former NFL player, we had multiple Division I basketball players, and of course, they put that right on their resume, and of course, it sticks out. So you just got to have some type of interesting fact about you per se. So
I put geocaching as one of my hobbies, and I got asked about it at every residency interview that I went to.
there you go.
Like literally everyone. Cleveland Clinic asked about it. Albert Einstein asked about it. University of Cincinnati asked about it. They all loved it. And so it doesn't even have to be anything like crazy, but sometimes you just have those little like fun things on your application that are just good talking points that make it fun during an interview. But they love that. I got asked that on every single interview I went on.
Kind of this just triggers something too, but make sure whatever you put on your application, make sure you know your application inside and out. So if you were part of like a research project and someone just threw your name on it just to throw you a bone, you better read that research project and have an idea what it's about. At least in cardiology fellowship, because like I said, it's a lot of the internal medicine programs, they kind of were a little more lenient, and they kind of just wanted to know like, grades, get to know you type of deal. But cardiology fellowship, when I went down to Marshall, I listed all like my poster presentations and everything like that. And then the guy sits down, he comes out of the cath lab essentially running late, sits down, and he goes, probably hadn't looked at my application the whole time, went straight to research. And he's like, oh, so tell me about this interesting case where you had like in-stent restenosis. And I'm sitting, and I was like, I already knew this was going to happen because I made sure I made myself like just like a little brief, paragraph summary of my presentation that I read actually the night before, because if you start listing projects from 3 years ago during residency or something like that, you might not remember it, but you need anything you put on your application. You better,
free game.
For one, it better be real. But if it's not like Zach, I don't think Zach has ever geocached.
I don't think he knows what that
I
is.
I did do geocaching. I did that. Yes, I did. Me and Corey did it all the time. All right.
All right.
Did a ton of
Cody,
geocaching.
who you with, me or Zach here?
I'm with you, Paul.
But it's true though. What he's saying, I mean, that's true for medical school. That's true for residency. If you put something on your application, you have to be able to explain it.
Yep.
You have to know about it, and you have to be expected to get a question on it, because you will. That's just a fact.
Yep.
Medical school, residency, always.
Yep. Interviewed for I think cardiology fellowship again up in Michigan. I hunt and fish, but of course the guy interviewed me was an interventional cardiologist again, and he's like, "Oh, you hunt and fish, right?" So then, what do you think he's going to ask? "Oh, what do you hunt and fish for?" Or, they always follow it up. So if you just blatantly lied about hunting and you have no idea what any wildlife is, you're going to be in trouble. So, just be able to explain yourself. I figured people would be wanting to know like funny stories about Dr. Burns. I really did.
Well, since we're getting close to the end of our time, I'll let you guys finish up by each telling a funny story. And
There it
then
is.
we'll say thank you to everybody.
What do you think? Oh man, funny story.
What do you know? Pollard somehow, I don't know.
I think the funniest one, truthfully, we were all there, Dr. Burns, all four of us. Okay. Funny and scary though, Dr. Burns. We were in the hot springs or warm springs in Yellowstone. And the snow's melting out of the mountains, and we get in the hot springs, and the current, you could probably whitewater raft on this current if you're out in the middle, and you have to stay along the edges.
Oh yeah, this is good.
We're all doing it. We're all along the edge, water's coming in, it's nice and hot coming in. Dr. Burns goes to get around us, and he decides, I don't know what he was doing. I don't know if he thought he was Jacques Cousteau or what. Steve Irwin, maybe, I'm not sure. But he decides to take like 2 steps out in the middle of this thing. And next thing you know, Dr. Burns goes downstream way past us. And all I hear is, this isn't good. And there he drifts away. I literally thought, I didn't know where you were going. I don't know how you got out of that current.
All right, I got a good one. Okay, that was a good one too. Watching Burns go by me as he's like getting ready to be taken away by this current. But then the best one was Andrew too. So we were all in our advanced anatomy practical, and we're all going around the room. Back then, I don't know how you guys still structure it, but back then they had different cadaver pieces all over the room, and they all had a tag on them. And so the tag had a number for a question on the test. And it was a big test. I mean, it was a lot to do. Dr. Oliver spent a lot of time on these things. We all did, since we were all, worked with him. And we're going around. Everything's really quiet. You could hear a pin drop in this room. Pollard goes off into a separate room, and I think he was looking at one of the tags, and he accidentally ripped it off. And you can just hear from this dead silence, this curse word come out of that back room. I think the whole lab erupted in laughter. It was probably one of my favorite moments.
I literally thought I failed that. This is literally Dr. Oliver's rule was do not touch the tag. I don't know why. I just reached down and was like, "Oh, where's this thing going?" And it just went.
Get the tag off.
Yeah.
I'm trying to think of Dr. Burns stories. Dr. Burns, you must have. I'm trying to think of anything. Cody, do you have
The
any?
current one was good.
Yeah, I can't think of any Burns stories off the top of my head. I had a few from organic chemistry. I feel like you can always tell the biology majors from the chemistry majors if you watch them measure something. And I was definitely a biology major, and I do a lot of eyeballing, and I was mixing something. I don't know if Dr. Trampy's still there, but I can't remember. I was concentrated sodium hydroxide. I think I was getting a melting point or a boiling point for one of our finals, and I remember it was like I was like waiting forever, and I was like heating up my Bunsen burner. And I looked away. I was like not doing anything. I was like talking to somebody. I looked back and it started bubbling, and I looked back again. It stopped bubbling. I was like, it's weird. I didn't do anything. And I looked away and it just blew up, and it just hit the ceiling. It just got showered. So the Trampy runs me over here, starts rubbing boric acid all over me. I was like, I was fine. I was just like, I think that one of many times. I did okay in the OChem lecture, but do not put me in that lab again.
Tons.
Okay, well, thank you guys for taking your time to talk with us today. And thank you to everyone in Pre-Med Club for coming today. And, you know, I hope to see you at future meetings. And I know Andrew, Cody, Zach, we'll be contacting you all the time for things like pre-med days and other things too.
Sounds good.
Yeah, I'd be happy to do it, and you guys are welcome. We can share our emails, and if you guys have any other questions or anything, feel free to reach out. Be happy to answer some questions for you.
If you could write that in chat, that would be very helpful.
Yeah, sure.
And an additional thing before everyone goes, this is in regards to elections. This coming week, we're going to put out a vote for the upcoming officers' positions. We have, I believe, 5 positions: presidency, vice presidency, the secretary, the treasurer, and the historian. We have Jacob Kielmar running for historian again. I'll be running for president again. Megan Long will be running for the vice president, and we have Laura Luthi, who is trying for the secretary position, and Hannah Thacker for the treasurer. And all of you are more than welcome to run for any position. Just contact Dr. Burns or I or anyone else, and we will get you on the ballot. Thank you.
Cool. Thanks for having us, guys.
Yeah, we appreciate it, guys. Thank you. 2-term
Yeah, thank you,
presidents, 2 terms. Dr. Burns, I didn't think you let us do 2 terms down there. We just had it was like Zach was president and then VP, and then like you just flip things around.
Yeah, sometimes it's hard to get other people to run. So
Yeah.
You can imagine, yeah. So thanks,
Thank you
guys.
guys.
Really
Again, really appreciate it.
anytime you guys want to talk or whatever, especially over Zoom, you know, that's one thing pandemic made is communication's a little bit easier. But if you ever need like just a guest speaker or something like that, I'd be more than happy just to jump on your pre-med club, or even just join your pre-med club meeting out, just to have alumnus presence, alumni presence. So it's fine.
All right, you guys have a good one.
okay,
You guys.
bye guys.
We'll see y'all later. Thanks, Dr. Burns. See you later.